Hello. So this is a bit of a gross one. If you're not into anything gory today, move along. But enjoy this. Don't try any of this at home. So this is a big, juicy, fat, ingrowing toenail, as you can see. There's a lot of inflammation at the sides, and the only way we're going to get this better is by taking the sides of the nail out. So we've got to numb it first. So this is a local anaesthetic. This is the not very nice bit. So I'm going to inject the base of the toe at one side and then the other. And the idea of this is that it's going to numb from the point of the needle up, well, where I put the injection site, and to the end of the toe. So we're doing what we call a digital ring block with this. So I'm popping the anaesthetic in there. Now we're going to leave this go off. So what I've been doing is trying to work and move around some of that anaesthetic. But before we go ahead, we need to check everything is numb. So below the point of the injection site is completely sensate, but above it should be numb. So I'm just testing here. So we'll feel sort of blunt sort of pressure and movement, but there shouldn't be any sensation of sharp pain. Now, as you can see, this toe is incredibly inflamed with a bit of local infection around there, and that can interfere with the anaesthetic and how effective it is. So sometimes it is necessary to top up, and in this circumstance or in this situation, it wasn't quite numb. So we've ascertained now that there are areas that haven't quite gone numb yet. So instead of going in at the base of the toe again, we're just going to go around those areas that aren't quite numb. Now you might be able to see as I put the injection in, I'm going very slowly here, putting small amounts, but you can see it's going white. It's what we call blanching. And that is basically where the anaesthetic is running, so I can see. So again, for the bits that you can feel when this local method of infiltration, it can be a little bit stingy, but often the patient is already reasonably numb from the original anaesthetic. So now we've tested again. I've cut that bit out. We've tested again, and he's completely numb now. So I'm going to put a tourniquet on. Now, this particular tourniquet is an Esmarsh bandage. And so what I'm doing is I'm exsanguinating. Now, that's a very wonderful word for meaning I'm squeezing out the blood. So I'm exsanguinating the toe of blood. So I'm winding down. So I'm squeezing the blood from the top of the toe back down into the foot using this tight band. Now, when I get to the bottom, I'm going to kind of clamp it off. Now, that's going to prevent any return of blood into the toe. So you will notice when I remove the tourniquet, this blue rubber bandage, that the toe will be a lot paler, a lot whiter than its other vascularized friends. So I always joke it looks a bit like a dead man's toe. Like I say, obviously this is completely numb now because otherwise he wouldn't be letting me do this for him. So now we've got it nice and exsanguinated, and we've prevented the blood now from getting into the toe. What I'm going to do is just remove, or like kind of separate the nail from the toe beneath. Now that just means I can get like a decent clean section. So this is quite a broad nail. These kind of ingrowing toenails tend to happen to sort of younger people, mainly males, but not, only males. It tends to happen with a broader, flatter nail. Playing sports, etc., can kind of cause these conditions. Basically, the nail kind of digs into the skin around it. You get a little break in the skin, then you get a bit of infection in, which bugs are everywhere, and then it swells up, and then you kind of end up on a bit of a slippy course. Now, these are called thwaite snippers. They were flat on the bottom side and cutty on the top. And so I'm just separating the piece of nail I want. Now, I'm not taking the whole nail. We're just taking the pieces that are causing the problem, which is a really good thing to do because when it's all healed up, it'll just look like a slightly narrower nail. So it will look kind of normal, to be fair. No one will really notice. Now I've cut the edges. I'm just making sure that those cuts extend down to where there's cells that make the nail, which we call the matrical cells. And I'm making sure it's a nice straight line and that it goes all the way through because A, I don't want to leave any of these matrical cells behind. B, because they will regrow. And now I'm using some mosquito forceps, like tiny little forceps, just to take the bit of nail out. Now you will see that I haven't been entirely successful in getting that full section through. So like I say, I don't want it to regrow. So I've lifted that bit up where I can see it, and I'm just going to snip it off there. And now I've got that piece of nail there. So I'm just going to show you there. Here we are. There you go. Sorry, it was a bit quick. And I'm going to take the other piece now. Now this piece comes a lot easier. I've managed to completely separate it. So I'm just turning it gently, and then out it comes. Now look at that big bad boy. Well shot of him. So now those pieces are out. The central piece that I've left will continue to grow as normal. But we don't want those side pieces to regrow. So I'm going to make sure that I've got all those bits out, because any little pieces of nail that I leave behind now stand a good chance of regrowing. So I'm going to treat it with a chemical to kill those cells that make the nail in those areas only. But if I leave any little bits behind, they can regrow. Now there is some bits of debris in here because, as you can see, these have been causing a problem for some time, and so you get like kind of little bits of what we call fibrous tissue, so kind of little bits of scarry tissue. You get little bits of kind of pussy bits like muck, fluff, all sorts of bits and pieces can end up down there, and I want to clear a bit of this away. Now those lumpy fleshy bits, what we call hypergranulation tissue, and they come, they're basically healing tissue that's gone a bit bonkers. And it's gone bonkers because it's trying to heal, but then you've got the bottom bit underneath the nail and you've got the top bit over the nail, but it can't get through the nail, so it keeps moving across the nail to try and meet the other side. And so while that nail is there, it's just going to keep growing. So it's important that we remove enough nail so that it's clear of this hypergranulation tissue. I'm just drying out the area now before I apply the chemical. Now, some of my colleagues will actually excise this hypergranulation tissue by just chopping it away, basically. Now, now I'm popping in the chemical here. So this is phenol. It's a very, very potent chemical. We're one of the very few professions allowed now to still continue using it. So we do this under very strict conditions. So it's a self-limiting chemical. So it's an acid. It will only burn so far. But I'm actually, as you can see with this hypergranulation tissue, I haven't chopped it away. I'm using the chemical to kind of try and burn it a little bit, but also shrink it back. But so those, basically the phenol kills the cells that make the nail. So I'm going to work it into the area where the cells that make the nail are. But I'm also trying to get it onto this hypergranulation tissue as well, because I'd like that to shrink back a little bit more. So I work it in, like I say, we do it under a regime where I expose the matrical cells and work it in for 1 minute. And then after that minute, I'm going to wipe out the area, dry it all out. And then I'm going to do the same thing again 3 times. So it's 3 separate 1-minute applications. Now, sometimes I will use a little bit more if I don't, because you get a feel for these things. I want it to feel kind of like sort of mushed up and just right. It's very hard to describe, but you just know when you've got it right. So I want to make sure. So sometimes if I don't think I'm quite there, I might just add a little bit more on. But ultimately, we do just 3 separate 1-minute applications. Now, some podiatrists do it slightly differently. I may go for 2 single-minute applications. Personally, I don't want these little fellows to regrow, and that extra minute doesn't cause any harm, but it does reduce any chances of regrowth. So that's why I do it. I justify my actions that way. So as you can see, I've wiped out the area, and now I'm going to reapply the phenol for my 2nd minute, and I'm going to speed this up a little bit in a moment, as you've seen me doing it already. So as I was saying, this hypergranulation tissue, this crazy healing tissue on the sides there. Now, some of my colleagues will excise this, like I say, but I'm using the chemical instead. But that tissue is absolutely jam-packed full of blood vessels. So that's why, if you'd notice at the beginning of the video, there was quite a lot of like bleedy, oozy stuff coming from that area. It's just so jam-packed full of blood vessels that we need the tourniquet. But also, if we don't kind of seal those off after the tourniquet is or before we remove the tourniquet, once we remove the tourniquet, it bleeds for fun, and it can take a while to get it to stop bleeding. And that can cause implications in the chances of regrowth. So if you get too much blood to the area, it can kind of flush away some of that chemical, some of that phenol, which again, we don't want. We don't want those pieces to come back. So ideally, we don't want it to bleed terribly afterwards. But like I say, it doesn't mean it will regrow, but it just means the risk of it is that little bit greater. Now, this doesn't seem to have speeded up with my wonderful editing, so apologies there. You're going to have to bear with me for the full 3 minutes. So I'm just using sterile gauze just to kind of, dry the area out. Now, the chemical does delay the healing process. So it becomes like a chemical burn for all intents and purposes. Here we go. Now we're speeding up. There we go. So if we don't use the chemical, the nail will regrow. Will it regrow any differently? No. It may grow kind of worse because we've kind of we've mushed about the cells that make the nail. But yeah, the nail will regrow. It won't we can't get it to grow any better, if you like. So there's no real bonuses for leaving it. There are occasions when we will do nail surgery without thing. Now, this hypergranulation, so it's kind of got like an eschar over the top there, which is like a dry kind of not quite a scab, but a dry area. So like I say, I'm going to remove a little bit of this, but I'm going to then zap it with the phenol. So it's just taking the tissue down a little bit. But yeah, I don't want it to bleed terribly after, but likewise, these were big hunky bits of hypergranulation. So I'm just removing that with the forceps there. And I'm thinking, right, I need to zap this just a little bit. So I'm just going to give it an extra blast of the phenol while we're at it. So like I say, if we don't use the phenol, the nail will regrow, but it will heal a lot quicker. When we use the phenol, we get the desired effect, as in we can end up with a pain-free toe, but the healing process is kind of dragged out a little bit because this becomes a chemical burn. So what we find is it discharges quite a lot. Usually for the first 2 weeks, it discharges the most, and then within that discharge, there are lots of healy bits and pieces, but it does kind of slow down the process quite a bit. Eventually, it will start to scab up from the end of the toe, working down towards kind of where the cells of the nail grow. That's the last bit to heal up, but it does take a bit longer because of the phenol. But we usually say we give ourselves give patients sort of 12 weeks for normal healing in a normal healthy individual. But the younger you are, the fitter you are, the healthier you are, the quicker it heals. Now, as you can see, I've removed the tourniquet, and straight away we've got a return of blood flow to the end of the toe, which is always very reassuring, because if we don't get a return of blood flow to the end of the toe, that kind of means no toe. So it's always a nice thing to see that toe pinking back up again. And what I'm doing is I'm waiting to see if we're having any areas of bleeding. And as you can see, we do. We've got a little bit of bleeding there. So what am I going to do? I'm going to hold some gauze to it. So I apply digital pressure, which basically means I'm just holding pressure to the area using my fingers and allowing the body to do its own clotting and to try and slow down that bleed. Now, this can take some time. It can be very quick. Many people don't bleed at all after the procedure. Some people do bleed a little bit, but the more hypergranulation you have, the more inflammation you have, the more likely it is to bleed after the actual procedure. So we've got just a slow ooze coming on the other side as well. So again, I'm going to apply pressure. Now, after a while, I made the decision that I could do with a dressing that was going to help with coagulating. It wasn't, say, a crazy bleed, but it just meant we could get this chap on his way. So what I've done is I've used an alginate, which is a derivative of seaweed, which is really good for helping coagulation and helping to stem a bit of bleeding. But I've actually popped that inside of a bit of a gauze. This alginate has a wonderful tendency to set like cement, and often getting it out of those edges can be a bit of a pain when I get the chap back to redress the toe. So I put him in a bit of gauze. That just means it's easier for me to remove it when he comes back for his redressing. I'm going to pop a clean sterile dressing over the top, and this is something called tube gauze. So this is just going to hold it all in place because I don't want it too tight, but on the same hand I want everything to stay there. And then I'm popping a bit of gauze over the top, and the chap's to leave this in place now for until we see him next, which is usually within a couple of days, and he's got to keep it dry until we see him for the redressing, where we'll put a lot smaller dressing on it for him. Gravity is a wonderful thing, so whenever there's bleeding or concern of bleeding, keeping the foot up is a really big help. So kind of just obviously when your foot's down, gravity pulls everything down with it, and so bleeding is going to be more likely in those situations. So I've put that tube gauze on, and now I'm going to tape it all down and make it nice and secure. And like I say, we get our patients back usually within a few days after the procedure, where we'll show them what to do is in redressing it. We'll give them everything they need, and they just get in contact if there's ever a problem. So I'm going to tape it down and make sure it's all intact and fine for going home. Usually, pain-wise, after the sensations come back, so when the anaesthetic is worn off, the pain doesn't tend to be too bad. Usually say take a couple of paracetamol rather than anything aspirin-based. Obviously, aspirin can kind of, well, thin your blood if you like, but it can make bleeding more likely. So yeah, we avoid aspirin-based products where possible. So paracetamol is usually all that's needed. But the relief after having been in pain for such a long time is really achieved straight away. Those are the bits of nail that we took kind of as you saw them from the tip. So that massive, huge piece there. But yeah, so much comfortable. But yeah, thank you for watching. I hope you found that very interesting and not too gory. Please remember to like and subscribe. It really does help us. And we'll see you again soon. Bye.